Hello, everyone. The paper I'm going to present today is called Uncovering Adverse Childhood Experiences from Clinical Narratives Within the Electronic Health Records. My name is Fayika Farhat Nova. I am the first author of this paper, and my co-authors are Shion Guha, Rachel Pfafman, Kelley Kardys, Connie Kerrigan, and Jessica Petter. Adverse childhood experiences, or ACEs, are potentially traumatic events that can take place in childhood from the age of 0 to 17. There are total 10 recognized ACEs indicators that fall into three categories: abuse, neglect, and household dysfunction. A current statistics by CDC states that around 61% of the adults surveyed across 25 states in the United States reported having experiencing at least one type of ACE before they turned 18, and nearly 1 in 6 reported having 4 or more events of ACEs. ACE is a global concern that influences health and well-being of a child throughout the entire lifespan and can lead to chronic health conditions such as obesity, depression, as well as risky health behaviors like substance abuse, dropping out of school, or even suicide. While ACEs are traumatic for all adolescents, some are at higher risk of being the victims and suffering more severely than others. Additional factors like cyberbullying, living in foster care, race, ethnicity, gender can also impact the severity of such events on youths. For example, a previous study showed the consequences of ACEs can be more severe in Hispanic communities relative to non-Hispanic adolescents. The majority of these studies, however, relied largely on publicly available data rather than actual medical records. Very few studies have tried to analyze actual patient data from EHR, which are often unstructured in nature with discrete lenses, which could potentially provide more reliable information on patients. However, due to limited guidelines on how this structured and unstructured data can be integrated in EHR, especially with a focus on ACEs, it's still a concern. Therefore, this study tries to address this gap in research and provide qualitative evidence on discrete lenses that may be used as a part of ACEs assessment for better collaborative decision-making on patients' health in the absence of a formalized diagnostic tool in acute clinical settings. We particularly explored the prevalence of ACEs within patients, especially who are cyberbullied based on their clinical notes. We also explore how discrete lens like gender and clinical diagnosis influence the presentation of ACEs within bullied patients, and what clinical and computational design guidelines can make these findings actionable in clinical settings during ACE assessment. The study was a retrospective chart review focused on Parkview Behavioral Health's inpatient youth hospital, which is located in Fort Wayne, Indiana, where we collected information on patients from their EHRs, including their diagnosis, demographics, and clinical narratives. We also used the cyberbullying screening data that the hospital has recently implemented for their younger patients. The clinical notes collected for admission and discharge are stored as unstructured data in free text forms. Two of our authors conducted a deductive thematic analysis on this data using the ACEs screener tool for creating thematic categories. In total, we had data from 719 patients who spent an average of 4.9 days in the inpatient institution and had an average age of 14.2. Majority of the patients were white and or Caucasian female. Based on our findings, around 32.9% patients in our study reported that cyberbullying contributed to their inpatient stay through the survey. However, this report was inconsistent with patient narratives from EHR, as many patients only reported being bullied in their narratives but not in the survey. Our further analysis showed while patients discussed a variety of ACE-related events in their notes, non-ACE indicators like involvement of Department of Child Services and adoption were very prevalent in connection to other ACE indicators in patients. While analyzing clinical notes gave us insight on patients' traumatic experiences, discrete fields like gender and clinical diagnosis further filtered out our results and provided nuanced results on the prevalences of ACEs within patients. For instance, almost all of the ACE-related indicators were higher within patients who indicated being cyberbullied. If we compare, let's say, a divorce between overall patient population and cyberbullied population, you see as opposed to only 6.7% patients, the proportion of divorce within cyberbullied patients was around 12.6, which is almost double. Gender also had an impact. For example, cyberbullied male patients reported higher engagement with serious physical fights at school, which also impacted their higher instances of facing probation. Additionally, the number of diagnoses of depression almost doubled within cyberbullied patients, especially females, as opposed to non-bullied patients. While the findings of the study showed potential benefit of incorporating structured and unstructured patient data to assess the impact of ACEs within patient, different socio-technical challenges like data inconsistency make it harder to implement the mechanism in place. As there's currently no proper guidelines or established mechanism to integrate cyberbullying screening information with EHR data, this can result in inaccurate assessment and can largely impact the multidisciplinary collaborative decision-making in clinical settings. So we recommended certain clinical and computational heuristic guidelines for improving the assessment and treatment outcomes of ACEs in clinical settings, utilizing both structured and unstructured data. For example, screening of ACEs and cyberbullying should be standard of care for adolescents in clinical setting, just as depression or anxiety. Data from this screening will provide clinical insights for the clinicians with more objective measure in assisting and treating their patients. Similarly, as gender has an impact on behavioral and cognitive consequences of ACEs within younger patients, inclusion of a broader spectrum of gender in clinical assessment is also necessary in clinical practices. We also recommended some computational guidelines that we believe can improve data-driven decision-making in clinical settings. For example, implementing automated ACE detection and notification can be a great way we can analyze large, unstructured, raw clinical narratives into actionable recommendations. Additionally, as healthcare domain is gradually integrating machine learning algorithms and predictive modeling to identify different health-related aspects within patients, it is important that we establish which ACE-related risk factors are included or excluded from the models to ensure minimum bias and maximum transparency in the algorithm decision-making process. While this study has made novel contribution to the CSCW literature, it has also some limitations. However, implications of this study certainly opens doors for the future explorations that can ensure better, more targeted treatments and outcomes for patients. I think that's all the time I had today. Thank you for listening to my presentation.